Welcome to IBD School 109, Mythbusters. In this video, we will present a top 10 list of 10 common IBD myths and confirm or refute them. Let's get started. At number 10, I need lots of extra vitamins and supplements. This is a common one, though not too harmful, except to your pocketbook. The vast majority of IBD patients, especially if doing well, absorb enough calories and nutrients. Nutrients are absorbed in the small intestine, so patients with colonic Crohn's or ulcerative colitis do not have a lot of nutritional deficiencies. Spending a lot of money on expensive vitamins and supplements is not necessary if you want to take a standard multivitamin. That's fine, but most supplements are overkill. There are some exceptions, and therefore there is a kernel of truth to this one. Patients with active inflammation for a long time will stop absorbing iron. Many infectious bacteria and viruses need iron to grow, and the body will respond to long-lasting inflammation just like an infection and reduce the available iron in the body. When this occurs, taking extra iron by mouth will not help, and in some cases, intravenous iron is needed. The other exception is vitamin D, which is often low in IBD patients, and it is important for strong bones. For IBD patients with thin bones, vitamin D can help calcium absorption and bone strength. Occasional patients with Crohn's disease who have a lot of damage to the last part of the small intestine will have trouble absorbing vitamin B12. If you have low levels, taking extra vitamin B12 by mouth may be sufficient, or you may need injections. However, most people with Crohn's have normal B12 levels and do not need B12 shots. And now, at number 9 on the IBD Myths Top 10 list, I need extra digestive enzymes. There's quite a market selling digestive enzymes and meat tenderizers on the internet. Fortunately, IBD is not associated with a deficiency of digestive enzymes. Most of the enzymes sold either don't work or get rapidly broken down in the stomach without doing any harm, except to your wallet. However, if you do get potent enzymes to the small intestine, they can actually cause damage in high concentrations. They can actually act like a meat tenderizer, damaging the bowel lining and the barrier between the intestinal bacteria and the gut immune system. This could even set off a flare, so staying away from digestive enzymes that actually work is probably a good idea. And now, at number 8 on the IBD Myths Top 10 list, everyone with IBD eventually gets cancer of the intestines. Fortunately, this one is not true. First, cancer of the small intestine is quite rare. Only about 6,000 people per year out of the 300 million people in the U.S. get small intestine cancer. People with severely inflamed small intestine from Crohn's are at increased risk of small bowel cancer, but it is still rare. Cancer of the colon is much more common. In fact, about 6% of healthy adults will eventually develop colon cancer. The rate of colon cancer in IBD patients with colitis used to be much higher, up to 18% in patients with long-standing colitis by 30 years of disease. But recent data suggests that this rate has come down a lot with the introduction and use of newer medications, so that recent studies estimate that this risk is closer to the 6% seen in patients without IBD. And now, at number 7 on the IBD Myths Top 10 list, a little bit of bleeding every day is fine, as long as it's a small amount. Bleeding means that there is a hole, likely an ulcer, that goes through the intestine lining down to a blood vessel. This is bad for 2 reasons. First, it is a sign of active, ongoing inflammation, which increases the risk of symptomatic flares and in the long term increases the risk of cancer. Second, it means that the barrier between the gut bacteria and the gut immune system is broken down, and this makes flares more likely to occur in the future. Active bleeding on a regular basis, even in small amounts, is a problem and suggests that you need a different maintenance therapy. And now, at number 6 on the IBD Myths Top 10 list, all of my kids will get IBD if I have IBD. Actually, only a minority of children of people with IBD will ever get IBD. For UC, this is about 15% of children, and for Crohn's, it's about 20% of children with one parent with IBD. While there is a genetic component to IBD, and in certain families the genetic component is very strong, for most parents, having a child with IBD is actually relatively uncommon. While genetic risk factors are important, even people who are genetically at risk usually do not get IBD. Some sort of additional event, like damage to the lining of the bowel, has to occur to start IBD. And most people at risk, the second event never occurs. And now, at number 5 on the IBD Myths Top 10 list, everyone ends up having surgery and an ostomy. While surgery is an important part of the care of both Crohn's disease and ulcerative colitis, it is far from 100% of patients who need surgery. Historically, about 30% of patients with ulcerative colitis require surgery to remove the colon. Most of these are in the first few years of ulcerative colitis and have surgery for uncontrollable inflammation. This rate may go down in future years with newer and more effective treatments. The rest of the patients have colectomy, the surgical removal of the colon for precancer of the colon, or even colon cancer if it is not found early enough. In contrast, about 75% of patients with Crohn's will require surgery after 25 years of disease. Many of these surgeries will be resection of short segments of intestine, and some will be strictureplasties, in which a narrowing of the intestine is reshaped and opened up without removing any intestine. While many patients worry that a surgery inevitably means ending up with an ostomy, an opening from the intestine to the skin on the abdomen, this only occurs in a minority of surgeries, when reconnecting the intestines would make the patient worse. This can be necessary in the most severe cases, but is uncommon. Most patients will be able to get their intestines reconnected after surgery. And now, at number 4 on the IBD Myths Top 10 list. People with IBD usually do something wrong, stress, bad food choices, or bad karma, to cause their own flares. This is not true. While it is common to believe that flares are somehow a punishment for being bad, this is not the case. No particular food can reproducibly cause a flare in all patients, and most patients can routinely tolerate stress without a flare, especially if their maintenance medication is working well. While food and stress do not worsen inflammation on their own, they can worsen symptoms, and this is the kernel of truth in this myth. Certain foods provide more nutrients to bacteria, which can lead to more gas, bloating, and pain. This does not necessarily worsen inflammation, but it can increase symptoms. And stress definitely does make the intestines move food through faster, causing more frequent bowel movements and diarrhea, even in people with healthy intestines. College finals are a classic example, when many people will notice more loose stools when they are under stress, and the caffeine and lack of sleep don't help either. There is, of course, an exception to every rule, and one kind of bad behavior is associated with more inflammation and flares, and that is not taking a maintenance medicine. A number of studies have shown that patients who feel better and stop their medications are much more likely to have flares. Talk to your doctor if you're thinking about stopping your maintenance medicine. And now, at number 3 on the IBD Myths Top 10 list, herbs and natural medicines help IBD a lot. While there are certainly herbs that can affect constipation and diarrhea, none have been shown to help the inflammation of IBD. It is very popular to try assorted herbs and supplements if your current medication is not working well enough. But most of these have no effect on inflammation, and a few can actually make things worse. Unlike FDA-approved medications for IBD, there is no regulation that requires supplements to contain any of what is listed on the label, or to prove that the contents are pure or active. Therefore, most over-the-counter supplements do nothing. But some actually have chemical effects and can interact with other medicines or cause problems of their own. For example, taking ginkgo increases your risk of bleeding, which is a problem if you have active disease and you are bleeding from your intestine in the first place. Always tell your doctor about any herbs or supplements you are taking and try to find out exactly what is in them. And now, at number 2 on the IBD Myths Top 10 list, prebiotics and probiotics help IBD a lot. Unlike FDA-approved medications, prebiotics, bacterial food, and probiotics, actual bacteria, do not have any regulations or requirements for purity and potency. Therefore, many probiotics may not even contain live organisms, or the organisms they claim to have. There is no quality control requirement. Beyond not knowing what is in the bottle, though, there is no requirement that these medical foods actually work in some way to improve outcomes in a disease. When you look at advertisements for prebiotics and probiotics, they're carefully vague. And if you read the fine print, they're careful not to claim that they are of any benefit for any disease, which is because they do not have any evidence of benefit in IBD. Even worse, patients with poor flow of food through their intestines often find that adding a lot of bacteria, probiotics, or bacterial food, prebiotics, to their intestines leads to the production of a lot more intestinal gas, leading to bloating, distension, and discomfort. There is some evidence that specific bacteria can be anti-inflammatory in specific genetically identical mice, but those same bacteria can actually worsen inflammation in other strains of mice. On occasion in sick patients, probiotics have been shown to harm people. One clinical trial of probiotics in acute pancreatitis was stopped because more people in the probiotic arm were dying in the study. It's difficult to claim that probiotics are harmless, especially in IBD patients with ulcerated intestines, as the ulcers would make it easier for probiotic bacteria to get into their bloodstreams. People are not bred to be genetically identical, like the mice that were helped by probiotics, and we have a lot of variation from person to person. So identifying a particular bacteria that might benefit you is hard. A lot of research is going into this field, but we have not yet, as of 2011, identified a particular bacteria or a mix of bacteria that is beneficial in all people with IBD. And many clinical trials have tried to do so without success. So you will see a lot of advertising and a lot of vague claims. But until we can prove a particular probiotic can actually help in IBD, none of them will be FDA approved for Crohn's disease or ulcerative colitis. And now at number 1 on the IBD Myths Top 10 list, I have to stop my IBD meds if I get pregnant. This is true for a couple of medications, methotrexate and thalidomide, which are both rated pregnancy category X by the FDA. But your doctor should talk to you about birth control and not getting pregnant long before prescribing either of these medications. Actually, most IBD medications, even steroids, are relatively safe in pregnancy, with FDA pregnancy categories ranging from B to D. Generally, for women who are sick enough to need a particular medication to control their IBD before they got pregnant, they should probably stay on it through the pregnancy. Going off your medication and having a flare is usually worse for the pregnancy than any risk from the medication itself. For men, there is evidence to suggest they should stop drugs like methotrexate and thalidomide at least 3 months before trying to conceive. But for most IBD drugs, there is little or no evidence to suggest harm to the sperm that would affect baby development. And that is our top 10 IBD myths list. Thanks for watching IBD Mythbusters.